Good morning, everyone. I'm Mark Weeks, and on behalf of the Florida Alcohol and Drug Abuse Association, welcome to today's webinar entitled Patient Retention in Medicated Assisted Treatment. This webinar is being made available through a collaboration of the Florida Department of Children and Families, Office of Substance Abuse and Mental Health, and the Florida Alcohol and Drug Abuse Association. Please note that as an attendee, you are in listen-only mode and will only be able to view your name if you have questions. Please send them to the presenter and me, the host, by using the Q&A panel. The button to open the panel is usually located on the upper right side of your monitor. Please use the Q&A panel to send any questions you may have as you think of them. The presenter will address questions as time permits. Our audio is broadcast through the internet to your computer. If you are experiencing poor audio, there are a few options to try on screen right now, and these options will be posted in the chat panel too. If you continue to experience poor audio through your computer, try rejoining the webinar and call in using the telephone I will call in option. You must be connected to audio of this presentation and view it on screen as well to receive a certificate of attendance. The recording of materials used in today's presentation will be available on the FATA website within 5 business days. To access the recording, go to www.fata.org. Also, a PDF version of the presentation will be emailed to participants within that same time frame. FATA produces many webinars and workshops through the support of the Family Department of Children and Families. To help participants track credits earned through attendance, we host an online community that provides a personalized digital journal where participants can maintain statements of credit for webinars and workshops taken through the Florida Alcohol and Drug Abuse Association. At the end of today's webinar, the web browser will direct everyone to an evaluation form on the FATA website. You will first need to register or sign in to your account to complete the evaluation. Information you provide FATA as part of the registration remains confidential. Statements of credit will be posted within 5 business days after the evaluation closes in individual professional development journals for persons completing the evaluation and attending the full webinar. Completing evaluations is necessary to receive CE credits or to access statement of credit. Do note that the evaluation will close at midnight on Wednesday, February 5th. 1 to 2 continuing education credits are available for participating in today's webinar for persons licensed through the Board of Nursing, the Board of Clinical Social Work, Marriage and Family Therapy, and Mental Health Counseling, and for those persons credentialed through the Florida Certified Board. If you are a licensed healthcare practitioner, be sure to include your Florida license numbers for reporting to CE Broker when you register with our site for the first time. If you are certified with the Florida Certification Board or licensed outside the state of Florida, you do not need to provide your certification number when you register with our site. Note, please, that WebEx monitors arrival and departure of attendees and provides a report upon completion of the event. We are not permitted to provide contact hours or certificates of attendance if you do not attend the entire webinar. We are not permitted to provide partial credit. And now let's welcome Dustin O.T. Perry. He is a licensed clinical social worker and certified addiction professional living in Pensacola, Florida. He holds a BA in psychology from the University of Central Florida and an MSW from the University of West Florida. Dustin is currently employed by Lakeview Center as the program director of the State Targeted Opioid Program and the Clinical Director of the Medication-Assisted Treatment Program. He oversees the daily clinical activities of the Pensacola Methadone Clinic, while also managing the State's Targeted Response, STR, and State Opioid Response, SOR, resources. Across the 4 most northwestern counties in Florida, these programs use the 3 medicated assisted treatments to help indigent clients live a better life. And we are very pleased to have Dustin O.T. Perry join us today. Dustin, if you're ready, I'm going to pass the control over to you.
Hi, good morning. Thank you, Mark. I appreciate you all joining me. We will have a brief intermission about halfway through the program, but feel free to ask any questions as they come up. We are going to be talking about patient retention in medication-assisted treatment. Let's see if we can get this working. All right. So today we're going to look at how to understand how to more effectively engage individuals prior to the treatment onset. A lot of times we look at, once a client's in with us, how do we retain them? But we also need to look at how we can get them into the right treatment on the beginning, the front end. We also want to learn how to increase the retention. So once an individual does start treatment, how can we retain them in services while they're receiving medication-assisted treatment? And then finally, we want to challenge reasons for administrative discharge from opioid use treatments. So why are we looking at this population? Why is this such a big deal? The Department of Health and Human Services has a 5-point opioid strategy, and one of those is better addiction prevention, treatment, and recovery services. That's where medication-assisted treatment comes into play. MAT Services has shown success in treatment and recovery of opioid use disorders. Our communities are losing their children, their parents, siblings, friends, neighbors, or employees to opioids. Individuals are dying, and that's what it really comes down to. Our friends, our family are dying. They're being incarcerated. They're put in jails. They're taken out of the communities. And they're also using medical resources in excess. So nationwide, about 2.5 million Americans meet criteria for opioid use disorder. 20% of those are receiving treatment. There were over 63,000 deaths in 2016 related to the drug, about 24,000 involving an opioid. 11.8 million people have opioid misuse. That means they're using it off-label. That's about 4.4% of the total population 12 or older. That's a very large percentage of the community using. And then heroin and fentanyl, particularly deaths, are rising. Now in Florida, we had a little over 6,000 opioid-related deaths. It was either the cause or it was present during the autopsy. 4,000 opioid-specific deaths. 1,500 synthetic opioid-related deaths in 2016. There were 200 in 2013, so that number is just continuing to elevate and rise. And then this neonatal abstinence syndrome, pregnant women are using opioids without treatment at an alarming rate. It's increased significantly in the last 15 years. So as you can see in the chart, some of the opioids are actually reducing between 2016 and 2017. However, the fentanyl and the fentanyl analogs have continued to increase. All these slides will be available later. So I'm kind of blowing through the stats a little bit so we can get to some of the more important pieces about how to retain. So what is our goal? What are we trying to achieve by providing MAT services? Retention and treatment must be based on our goals. We decide who remains in treatment and who does not. If our goal is 100% abstinence, then our retention is going to be based on that goal. If our goal is to reduce deaths, then we have significantly more opportunities for retention than 100% abstinence. So the primary goal of treatment is to keep people alive, out of the hospitals, and out of courts. When these basics are met, when we can eliminate the deaths, when we can eliminate hospitals, when we can eliminate jails, then the individual can focus on their secondary goals, typically what the client says when they come into treatment. So secondary goals, we want them to build a purposeful life. We're looking for medical stability, improved relationships. We want them to get involved in the community, become employed so they can do things like pay taxes and take care of their families. We want them to engage in hobbies, build communities. These things aren't possible if they're dealing with those primary goals. So we've got a specific case study here. This is an individual that we dealt with in the last few months. So this individual, he presented for detox with opioid withdrawal and a hopeful admission into residential program. The client also has the diagnosis of amphetamine use disorder and is currently homeless. The client expresses continued cravings 2 to 3 weeks into the residential service, and his family pushes him to explore methadone. The residential service allows the current methadone client to dose at the local clinic while in services, but they don't support bringing new patients in while they've started an abstinence-based program. The residential program does support naltrexone, but does not have policy and procedures on Suboxone. So residential links him with case management. So the client understands that he can't start methadone while in residential services, but indicates to the case manager that he is open to learning more about the methadone clinic. So the case manager reaches out to the methadone clinic to schedule a session for the client. So the client attends an orientation session and indicates that he never wanted methadone, but his family pushed him in that direction. Family members are using methadone, and the client indicates that the family is how he got started on opioids originally. The client is then referred to buprenorphine. The client states he's been successful on buprenorphine 3 times in the past. So the methadone counselor reaches out to the buprenorphine clinic, sharing that he can't start taking the medication until he completes the residential program. A staff member from the buprenorphine clinic meets with the client to discuss the benefits and risks associated with Suboxone treatment, grant funding opportunities, and tentative doctor dates that may line up with a departure from residential care. So what happened to this individual? This is an individual that wanted treatment. He sought treatment, but treatment services weren't available to him, and he was linked with the wrong services. Nobody was asking the right questions. What could have been improved? What could we have done differently with this client to ensure that he gets the treatment that he needs from the beginning? Why is medication-assisted treatment not approved in our residential units? And who's responsible for the individual? Was the individual responsible for finding the treatment for him? Was it the case manager? Was it the counselor at residential? Who could have played a role in impacting this client? The unfortunate news is that the client left services and never returned. He left residential, he relapsed, and we haven't heard from him since. So who receives medication-assisted treatment? Primarily adults. I did some searching. I couldn't find any children programs that work with Suboxone or methadone for individuals under 18. So it's primarily adults. Prior treatment attempts should be considered, but that's not a requirement. An IV drug user shouldn't have to go through an outpatient or residential unit to be considered for medication-assisted treatment. And then we've got our priority populations, pregnant women, IV drug users, child welfare, and incarcerated recent release individuals are at higher risk of relapse, and it's important to connect them with an MAT service. And we've got MAT versus abstinence. That may be an option for individuals with the opioid or alcohol use disorders. And then we've got the community-based treatment as well. We've got 12 steps, so Narcotics Anonymous, Cocaine Anonymous, Alcoholics Anonymous. Recently, we've heard more and more about Mar-Anon. We don't have that in our community at this point, but we've had some clients express interest in forming those groups. And then the faith-based community is the most excellent way to celebrate recovery. And we also have naltrexone. Naltrexone isn't traditional medication-assisted treatment. However, it's a very important tool in recovery. As we all know, a return to use is generally more common than continued maintenance or abstinence. So while naltrexone is not a daily medication or treatment style, It plays a critical role in our primary goal of reducing deaths. Emergency medical services should always be contacted when naloxone is used, as the effects of naloxone are short-lived and the individual could deteriorate following revival. Family members should be aware of how to obtain and use the medication, as well as other key individuals in the individual's life. I relate naloxone a lot to seat belts. 40 years ago, we didn't have seat belts in cars 40, 50 years ago. And now they've become just a requirement of cars. If you want to drive, you wear a seat belt. It protects you, and you may never need it, but it's nice to have. So the standard of care, the new SOR guidelines, for those of you that will be using the SOR funding, medical withdrawal and detox is not the standard of care at this time. It's associated with a higher rate of relapse, and it can lead to serious risk of opioid overdose and death. An individual, the tolerance may reduce in the few days of detox they go out and use, and it puts them in a situation where overdose is very likely. It is permissible when accompanied by long-acting naltrexone with Vivitrol. And the expectation of the SOR funding is that all FDA-approved medications be accepted at all levels of care. As I mentioned prior, we currently don't use medication-assisted treatment on the front end with our residential units, and that's something that we have to change as well. Then emergency department and peer support. The emergency departments should be linking with the buprenorphine community providers. When an individual overdoses or shows up to the emergency department, it's important to connect them with the providers so that they don't return to the community and use. We're no longer in the pilot phase of these programs. This is a state initiative that we are now a standard component of the system of care. Then also the recovery peer programs. The peers should be available and on call 7 days a week, and they should be able to bridge between the emergency departments and treatment. Individuals, when they overdose, they don't trust doctors, they don't trust counselors. What they look for is that individual that has that experience that they do. One of the most frequent questions that we all likely experience is, are you in recovery? So having that person that is in recovery and can push them towards treatment is a very nice way to bridge that overdose into that treatment. So what medications are available? We're not going to go into great detail about the 3 medications. I think at this point, if you're on this call, you should be familiar with them. But methadone is a full opioid agonist. It's been in practice for 50 years. It's used orally in the practice setting. It's primarily on-site daily dosing, with the exception of takeouts or pain management clinics may prescribe it. And then it has the highest rate of retention in medication alone. So as we progress further, we'll discuss the behavioral therapies, but if an individual is only going to take a medication, methadone has been proven to retain clients longer than buprenorphine or naltrexone. Then we've got buprenorphine, which is usually referred to as Suboxone, a little bit easier to pronounce. And that can be used a variety of ways. So over the last 2 decades, it's become more and more common. It can be used orally or sublingually. It can be implanted, and then over the last year or so, injectables have come out on the market. It's used with naloxone most commonly, and that prevents it prevents injections. It will put the individual into the withdrawal, which is never an outcome that the client wants. Waiver is required to prescribe in the office-based setting, the Data 2000 waiver, and then you can provide take-home prescriptions for up to 30 days. You can also provide this in a clinic with the daily dosing as well. Then naltrexone, the opioid antagonist, it can also be used in the alcohol treatment. It reduces cravings and the intensity of consumption. It was approved for medical use in 1984, and it also can be used orally, injectable, or the implant. Most commonly, I think in Florida now, it's used in the injectables with the Vivitrol program for the last decade or so. So with the 3 medications, comparing methadone and buprenorphine, methadone as medication alone is far more effective in retaining clients at 4-month review and 6-month review. Now, Suboxone was very useful in retention compared to a placebo. And then transitioning people from Suboxone to Vivitrol, when there's a 4-week taper, it really increases the retention significantly, about 50% retained in treatment. One of the things that's typically not discussed in these comparisons is the cost. Historically, going to a doctor in town to get a Suboxone prescription, there's a large upfront fee for the doctor visit, anywhere from $300 to $400 in our community, plus the cost of the prescription, which could be another $300 to $400, if not more. For that first month, you're looking at $600 to $800. The following months, the doctor visits reduce anywhere from $150 to $200, depending on the provider, and then the cost of the prescription, and it all tends to be at an upfront. And when you're looking at long-term cost, it's very difficult to have somebody that's struggling with addiction to come up with $400 to $600 in one setting and not use it on other drugs. Now, the methadone clinics, they tend to be that daily dosing fee. Locally, our clinic, I think, is the $14, and there's a provider in town that also goes up to about $17 a day, which is a little bit more manageable, which would make sense in this retention piece when it's easier to pay for methadone over a long period of time than it is to pay for buprenorphine at one point. So how do we get the client in the right service? We start with the screening. Will the individual commit to the service? If the individual comes in and says, I'm never taking methadone, it seeps into your bones, which is, of course, nonsense. You'll never come off of it. Why would we push them towards a substance that they're not interested in when they may be interested in buprenorphine or they may be interested in the abstinence-based programs? It's important to push them towards the direction that they're willing to attend. While we know that certain medication-assisted treatments work better for certain individuals, if they're not going to buy in, we need to really consider whether it's the right fit. So users of heroin compared to users of prescription-only opioids. Users of heroin, they often have less formal education and income, and they have higher risk of disengagement. And some of that is that users of heroin tend to seek non-medication-assisted treatment programs. They look for those abstinence-based programs, and they seem to gravitate from 100% heroin to 100% non-opioids. They're also more likely to disengage because of that. Now, users of prescriptions only are more likely to be engaged in MAT and be retained. So what this means to me is that users of heroin need more wraparound services. They need case management. They need individuals. They may benefit from that peer engagement as well. Somebody that can be with them more frequently and say, hey, I know what you're going through. I've been here before. Maybe we can get you in with psychiatry. Maybe we can get you housing. Maybe we've tried this abstinence-based and it's not working, so maybe we can look at this other medication-assisted treatment. So we'll go back a slide. So again, the client to the right service on the front end encourages retention in the long run. So this is harder than it seems and should be evaluated frequently. So while we can admit clients to a level of care based on ASAM or other criteria, a client's success at that level of care may not be evident for a period of time. We should constantly be reviewing their status to increase or decrease the intensity of services to meet their needs. So looking at the right services as well, barriers. Is location going to be a barrier? So in Pensacola, we're up here in the panhandle, kind of away from the rest of the state. If you travel 30 minutes north or to the next county to the east, there's no public transportation. If you have Medicaid, you can find transportation, but there's no buses. Getting from one town to the next is really a feat if you don't have transportation. So how can we meet the client where they're at? So an individual that is 30 minutes north of Pensacola that can't get on the bus, daily dosing at a methadone clinic is probably not going to work for that individual. It may be the right fit, and that may be what they want, but if they're not going to make it daily, we may need to look at something like buprenorphine, where they get a prescription once a month, or the long-acting injectables. So the cost. Will the cost be a barrier in the future? Some individual may present and their family is tired of them stealing, or they're tired of them being in and out of jail, and they're ready to pay for the intake fees at the methadone clinics or the buprenorphine. What happens when the family gets tired of paying? Will the client be able to retain those fees? Will they be able to continue paying on a long-term basis? Now, with the grant funding, that's typically not an issue, but will the individual be capable of finding employment so they can carry on when the grant funding is over? Clinic hours. If your clinic doses from 6 a.m. to 11 a.m. and the client works from 5 to 1, are they able to dose? Are they able to take off from work? If they're not able to, is there another clinic in town that does have better dosing hours that meets the client's needs? Maybe one of the other medications is also a better option. Maybe the buprenorphine or the long-acting naltrexone is more suitable for that individual that works but is unable to attend the clinic hours. Housing. If the client doesn't have stable housing, then takeouts. I apologize. If the client doesn't have housing, then takeouts or buprenorphine, is that going to be more appropriate? We obviously don't want to give somebody methadone if they're sleeping out in the woods in a takeout box, or a prescription for buprenorphine for a month if they don't have a place to lock it. Transportation. If the client doesn't have transportation and one service is on the other side of town that the client is the best fit, should we link them with the right service instead of the one that is going to be difficult for them to get to? All right, so we have pre-engagement staff. This is our admission staff, our administration, and the front desk. Now, customer service. We're selling a service here. We may not be selling clothes or houses or food, but we're selling a service to an individual. So we want the individual to feel welcome when they come in. We want to greet them well. We want to talk to them as if they're an individual and not. We don't want to talk to them in a negative fashion. What do they see when they walk in the front door? Does the clinic look like a clinic from the movies, or does it look like a legitimate medical office? You know, you see those clinics where they're run down, and you kind of worried about going in even as a staff member. Can we change the decor? Can we paint? Can we make it look more modern? Earlier this month, I had to wait 30 minutes to see my doctor, and the first thing he said is, "Have you seen a doctor in the last year?" And I had seen him 3 times last year. That's not a doctor's office that I'm willing to go back to. Is that how staff is treating the new individual or an ongoing individual? So single point of access is something that's been very successful for Lakeview Center. I've been responsible for every Vivitrol and STR admission in the last 6 years. So everybody that comes into the program, they know who to contact. They know what they're going to get. They've got one person coordinating care. They've got one person that can talk to the doctor, one person that can talk to the nurse. They don't have to go through multiple people to get an answer or to possibly be lost in the shuffle. If you don't have access to a single point of access, or there's too many people, are all the staff sending the same message that recovery is possible and that there's hope on the front end? When an individual calls, we want to let them know that there is hope and that this is something that they can get through. How long is the time from the call, opening the front door, to orientation or screening? Are you losing individuals that call and they can't see a doctor for 2 or 3 weeks? How much is this going to cost? The front end staff needs to know these things. What services are available? Does all the staff have awareness of the medications available to the individuals? And do they favor one treatment? Is that left to the screener? If you always get one person on the phone and they always say, all right, Suboxone is the answer for you. Are we really meeting the needs of the client? And how long is this going to last? If you want to continue receiving the medication after a certain time period, is there a provider they can transfer to, or can they pay out of pocket or insurance? And this is especially important with the grant funding. Many clients will get on their feet and become employed or gain insurance. Will they be cut off, or is there a smooth plan for transition? Are there any other questions on the front end that need to be asked? All right, so engagement in treatment. We've discussed what's available to the individual, how to enter treatment, and barriers to treatment. We're going to take a look at how to engage the clients when treatment has started. We'll look at when to initiate medications and counseling, suggestions for engaging staff, different behavioral therapies to assist with medications, and drug screenings as part of MAT. So when do we want to initiate the medication? My experience is that with buprenorphine and methadone, clients that start on these medications may or may not have a desire to start counseling. It's critical to focus on treatment of the medical symptoms prior to the client being able to engage in counseling services. So treatment goals prior to dosing tend to be gruff and immediate needs. I want to stop feeling like garbage. I want to start to live. I don't want to live like this anymore. They're very short-sighted, but immensely needed goals, and they're met with the introduction of methadone or buprenorphine. When somebody starts dosing, they no longer feel terrible. They start to begin to feel well. So the client's symptoms tend to be resolved within a few days, if not hours. The chase for their next hit has been resolved. The dealers, the streets are not as concerning. So that's when counseling is able to kick in to help relapse prevention and teach the early recovery skills. So engagement in groups, individuals, family sessions become critical to maintain the abstinence from the previous lifestyle. And methadone and buprenorphine tend to resolve the cravings and withdrawal, but won't eliminate the client's desire to reunite with toxic relationships, engage in risk-taking behaviors or communities. Now with the injectable naltrexone, it's difficult to start naltrexone due to the abstinence requirements. We've only treated those that are actively engaged in counseling services, whether it's residential or outpatient. So we've only treated those that are actively engaged in counseling services. Our success with the Vivitrol program has been due to counseling preceding medication. It takes an opposite stance from the buprenorphine and methadone. There was a question, you're selling a service, what is the 5-year success rate? I think that when we look at the success rate of individuals, whether it's 5 days, 5 months, or 5 years, we have to look at well, cancer does use a 5-year remission. I don't know that medication-assisted treatment has a timeline. There's not a timeline that I'm aware of. Other people may have an answer for this, but I don't have the timeline of how long an individual is successful. My experience is that if somebody is able to maintain employment, maintain relationships with their family, if they do it for 6 weeks, they're successful. If they do it for 6 years, they're successful. Relapse or return to use is very common. And I think this is it's actually a very difficult question for me. So part of what we're doing in retention is that we want to keep people for a very long period of time. I think that we need to move away from the idea that we can get people in and out of treatment in a very short period of time and then they can go on with their lives. We've got some individuals on our methadone clinic that have been there 15 or 20 years, and they're able to manage their life day to day. So I would say that they're successful. We've got others that they get on the clinic, they stay well for 6 months, and they decide to taper off, and they go to meetings, and they do very well. So each individual is very different when it comes to success. I don't know that we can quantify a 5-year success rate here. And I know that may not have answered the question, but it caught my attention. So returning to the medication initiation with naltrexone, The model that Lakeview uses here is that we get our individuals, they see a doctor twice a month. So we've got 2 events that they can see the doctor. Each month, they come in and they get the injection on the same Friday. So this Friday will be our injection date. 4 weeks from then, so March 1st will be the next, March 29th, and so on. So every 4 weeks, and we treat anywhere, we're a smaller clinic, so we treat anywhere from 20 to 30 individuals per month on an ongoing basis. So 20 to 30 individuals funnel through a nurse's office over a 2 to 4 hour window, depending on when they show up. They continue to see each other. They have a discussion about what they've done in the last month. Somebody that's got 4 injections talks to somebody that's getting their first and says, "This is working for me. This is really powerful." We've almost built a community just on that one day a month where they come in and they all interact and they share and they build on their success. Additionally, they see their counselors. They see that person that they felt was very connected with their recovery, and it encourages them to get some feedback and some praise from their counselors, and also gives the counselors an update, which encourages the counselors to feel more that what they're doing is powerful and impacting the client. All right, so engaging staff. Knowledge of opioid use disorders. I think this is a piece that a lot of individuals that get into the substance use field early on may not be aware. They don't really know opioid use disorders. They say a little bit more than just stop if you want. They get that it's more difficult than that, but they don't know opioid use disorders. They don't know the current status. So getting staff that's trained in how substances impact the brain, trained in current treatment practices. They understand how substance use in the lifestyle is generally more complex than the average person. The staff understands that clients presenting with anger or toxicity are often dealing with more than what the individual is presenting. Mood fluctuations, emotions, undeveloped relationships, and expectations of immediate gratification. The staff should be knowledgeable, and this includes support staff, counselors, nurses, or anyone coming in contact with these individuals. It could be the tech. They need to be flexible. This is how it's always been. It gets us into a lot of trouble. So current practice dictates co-occurring treatment with inclusion of mental health and medical services. It hasn't always been this way. At some time, it was mental health staff. They were saying, if you have an opioid problem, we can't treat your anxiety here. Let me give you a referral. Substance use people say, you have anxiety. You can't work on your opioid problem. Let me refer you there. And the client goes home and uses more to deal with the helping community. So we kind of laugh at this practice now. What are we going to laugh at in 10 years? What are we doing today that 10 years from now we're going to say, oh my goodness, I can't believe that we were doing that. So our practice has to be adjusted to meet the clients and how it is now, not how it's been. And some of that practice is moving towards further integration of medical services into treatment centers, or vice versa, as well as harm reduction strategies. Staff should be trauma-informed. Does the staff recognize that the majority of our clients have experienced some form of trauma in their lifetime? Are they willing to make accommodations to respond to the client's desire for adjustment? Sometimes observed drug screens trigger trauma. What's the staff going to do to make accommodations to make the client feel comfortable? And are there alternatives available? If being observed during a drug test makes you uncomfortable, what are you going to allow the client to do so that we don't discharge them for not providing? And then referral sources. Clinicians should be well-versed in the basic therapeutic activities encountered on a day-to-day basis, but they should also have a list of referral sources at their disposal. Where does the client obtain that trauma counseling? What about extensive marital counseling? The behavior techs should be able to connect a client with transportation services or a local dental office that accepts indigent or Medicaid clients. Now, the use of recovery-oriented language is very important. I am not well-versed in recovery-oriented language. It's not a strength of mine. But this is one of those things that seems very minor, but it makes an impact. So you recognize the individual first and the problem second. So it creates an environment of respect for the person. For example, Johnny is an opioid addict defines who Johnny is. So how do you escape who you are? If Johnny is an individual who uses opiates, it doesn't define him. Johnny is an individual. He can recover from opioid use, and he's no longer an opioid addict. He's now a recovering opioid addict. Johnny is an individual who recovered from opioid use. Or he's Johnny who enjoys fishing and spending time with his kids. So encourage positive phrases and recognize the client's strengths over what is wrong. When the client says they fail, maybe suggest that they are resilient in their efforts. Encourage hope and recovery as outcomes. So I did some digging, and actually FATA has a resource section that has a great presentation on recovery-oriented language if you want to learn more about that. So the standard of care with the state opioid response is meeting the individuals where he or she is. We can't continue to provide business as usual. The stats presented earlier in this presentation show that this is a problem not resolving itself, and we aren't ahead of the curve. We have to reconsider how we treat and what steps we can take to help reduce the primary goals. Those are the prevention of death, incarceration, and medical excessive use. So we need to accept positive changes. Did the client show up every day this week but did not attend counseling? I encourage the individual to show tomorrow. Did he report that he has reduced his meth use from 7 days a week to 5? Accept those changes. We can't expect changing lifestyles overnight. It often takes years to get to the point where they show up, and it might take years to get to their goals. If we can accept positive change and promote primary goals, the secondary goals will hopefully be met in time. And we must prevent barriers to admission or retention. This is one of those areas that is going to be a difficult piece for a lot of counselors. Counseling services are valuable, and we'll discuss that shortly, but it should not be the barrier to retention. The medication will support the primary goals, while counseling will support secondary goals. It may be that a counselor has to meet the client when they come in for dosing or to see the doctor until the client is able to take the steps necessary to engage in scheduled services. We don't want to push the individual out of services, out of medication because they're not attending their counseling sessions. It's a very difficult thing to do as a counselor, but we have to recognize that this is something that we have to do differently than we have in the past. And return to use and rule violations are a symptom of the disease. These issues should be addressed and not result in the immediate discharge of the client. So behavioral therapies. Medication alone. So medication has shown better retention. Methadone has shown better retention than buprenorphine in medication alone. Medications with therapy, there is increased retention. Individuals tend to stay in counseling much longer individuals tend to stay in treatment much longer with better outcomes when they're doing therapy in addition to medication. A variety of studies found that the degree to which clients remain in services increased, but how much was different in each study. One of the studies found that when combined with weekly individual counselor or group therapy, retention rates between medications were 85% at 3 months. So whether it's buprenorphine or methadone, if the individual's in, up to 85% at 3 months. Contingency management is one of the only behavioral therapies that has shown increased rates of retention. Now, contingency management is the practice of incentivizing clients to follow program structures. Rewards could be for achieving a negative drug screen, attending all counseling sessions, or something as simple as showing up every day for the first week of dosing. Studies have shown the value in voucher-based systems and prize incentives. In voucher-based systems, clients receive a voucher that they can be turned in for an item that supports a drug-free lifestyle. It could be movie passes, food items, or similar goods or services. Now, prize incentives, the client would have an opportunity to draw from a bowl for a chance to win a prize that varied from small, maybe worth $1, or to large, maybe worth $100, and the number of draws can increase with continued successful events. studies did find that prize incentives did not promote gambling behavior. And that's always a concern, is that if I do this, it's gambling. I'm putting myself in a lottery. But there was no evidence to show that it promoted the gambling behavior. In one study, contingency management was found to be the only behavioral therapy to show promise as an intervention to increase retention in MAT for opioid dependence. Contingency management is controversial due to the idea that paying clients to do what they're expected teaches poor habits. If a client remains in treatment due to potential payment, we are achieving those primary goals. So while it may be controversial, it is rewarding. In one study found that a small increase in payments for daily dosing increased retention greatly. Sources of payment are also difficult to obtain. Not a lot of people are interested in donating to somebody that continues to do something that is expected of them. If we can't buy into this as professionals, how do we get the funding to provide these rewards to individuals? So other behavioral therapies. Other behavioral therapies have shown increased retention, but there's little to no effect based on the style of therapy, whether you do cognitive behavioral therapy or motivational interviewing. 85% retention at 3 months. So other behavioral therapies, little difference between the two, whether it's supervision of medication consumption or additional counseling, education, or support, fail to find differences between intervention and control conditions. So when an individual does engage, the style of therapy or the style of behavioral modification doesn't impact it, with the exception of contingency management. And phone contact. So telephone support did not benefit retention rates above usual care. One study did find that 3 completed support telephone calls did have higher retention rates than patients in usual care. And I'm not sure that provides any significance to provide that extra phone support outside of just the one study. So essentially, as long as an individual has access to behavioral therapies, the retention rate is increased beyond medications alone. So take the client preferences into consideration when assigning group or individual therapy. What does the opiate use disorder individual say when they feel comfortable doing? If they feel anxious about groups but will engage in individuals, we should accommodate and provide individuals. If the individual is providing negative drug screens with the exception of prescribed medication, is engaging in some counseling services, and it needs additional takeouts for employment reasons, there's no evidence that reports higher retention rates because of daily dosing at the window. What the research shows to me is that individuals with opioid use disorders remain in treatment services because they are engaged in a community. All right, so we have another case study here, and I like this guy. So this individual, he's got a history of using opiates, amphetamines, and cocaine, and he begins treatment with an opiate or an injectable naltrexone in a residential treatment program. He abstains from substances for a 60-day period, and he receives the injections about 2 weeks prior to leaving treatment. He gets out, he gets a job, everything shows up very well when he comes for his next appointment. He's now getting his second injection, he's working, his family life is going well, but he comes in for his third injection and he immediately reports that he used methamphetamines and cocaine. He started this new job and some of the coworkers use, and he's very disappointed in himself. But he wants the help. He's worried that if he can't continue the Vivitrol, that he's going to go back to the opiate use. So he knows the risk of opiates, overdose because of the fentanyl in the area, and he's motivated to get the Vivitrol injection. He just can't shake the stimulant use because it's tied to his employment. Every time he goes into work, the people are there, and he can't leave work because he needs the money to pay for housing and food and all the things that we all need money for. So the drug screen comes back positive for meth and cocaine with the absence of all opioids tested. So he's given the opportunity to continue Vivitrol and urged to continue to attend support groups. the last time that he was in, he reported that when he left treatment, he got involved in 12-step meetings, and it was really helping, but when he got into work, he stopped going. So we pushed, let's go into 12-step meetings, let's get you back where you were, and then let's see how things go. So he let me know a few days later that he was going to meetings and that things were looking up. But he shows up for his 4th injection, and he's positive again. He knows that he needs the job. He knows that it's harmful. He wants some additional treatment, so we set him up with the intensive outpatient program. He goes to the intensive outpatient program for about 2 weeks, and he's still struggling. He's not able to kick the cocaine and the meth. Eventually, he leaves work. He goes back into the residential program to focus on the methamphetamines and the cocaine. So is this individual successful? If he didn't return to treatment, how long should he be treated with injectable naltrexone? Well, we know that methamphetamine and cocaine use can be very dangerous. The opiate use was the danger for him for overdose and death. And who was in control of the situation? Who was the one that was responsible for the treatment? The client was in control here, and the client, with guidance, was able to make some positive decisions. I feel that he was very successful. He completed the residential program again, and he's been able to abstain in the community, and he will get his next injection this week as well. So why do we drug test? Is our role as treatment provider to punish? Of course not. Our role is to help clients manage their problems and to push towards reduction of harmful events. So our primary goal is to save lives and reduce community risk. Diversion testing is important to ensure the clients are taking the medications as prescribed and not selling, bartering, or misusing. So the absence from non-prescribed medications, to what degree is acceptable for your practice? Regardless of the positive substance, effort has to be placed on engaging the client in reduced use of the substances well in advance of considering administrative discharge. So this includes scenarios where the client is encouraged to attend more counseling services, step up to the next level of care, revoking takeouts, or increase contact with clinical, nursing, or administrative staff to promote reduction in the use of non-prescribed medications. So these medicines have a significant medical interaction with the opioid replacements. Obviously, opioids, if you're using opioids while on replacement therapy, creates the obvious conflict. Why is the individual using more opiates? Is their dose correct? Are they experiencing withdrawal? Is their environment supportive of abstinence from other medications? Or is there a pain or trauma they are trying to mask? So these are the questions that need to be asked when an individual continues to use opioids. Now, benzodiazepines, this is a tricky one. The use of benzos in excess can result in the individual going to sleep and not waking up, which is clearly a primary goal of ours, to reduce that. Now, according to one study, more than 30% of overdoses involved benzodiazepines. Another study found that 17% of individuals with prescriptions to opioids also had a prescription to benzodiazepines. So the prescribing community allows it to some small extent, and we often trust what other doctors allow. If your friend's doctor prescribes Xanax with an opioid, why would it be harmful for you to take Xanax with methadone? How will your practice address ongoing benzodiazepine use? Is there an acceptable dose to prescribe to someone that is taking Suboxone or methadone? The non-medical use of benzodiazepines is of greater risk with methadone than buprenorphine. Now, I work with two different providers that do buprenorphine or methadone. They both disagree on the practice. One of them will prescribe low doses of benzodiazepines to clients using buprenorphine that have tried other medications, but with more frequent oversight. The other provider does not support any use of benzodiazepines with buprenorphine or methadone, and will meet with the client frequently to review the drug screen results. And if continued use, we'll recommend more intensive treatment, such as intensive outpatient or residential, for the safety purposes, or if that won't work, they'll taper them off of medication-assisted treatment. Alcohol, similar to benzodiazepines, alcohol can create significant complications with Suboxone or methadone. Now with naltrexone, the concern may be that the individual consumes excess to overcompensate for the medication, resulting in medical emergency. Is there an acceptable use of alcohol while taking medication-assisted treatment? The providers I work with have similar thoughts to benzodiazepines. A drink or two watching football may be acceptable to one, but unacceptable to the other. And with additional lab testing, alcohol can be detected much longer than traditional breathalyzers. This is going to be up to the prescriber that you have at your agency. Some of them are more comfortable than others, and there's not a one-size-fits-all here. We know that there are dangers of using benzodiazepines and alcohol with medication-assisted treatment. Now, these substances have a less significant medical interaction with opioid replacements. Cocaine, it can diminish buprenorphine concentrations and can lower the rates of retention in treatment. Marijuana and amphetamines, they have the ability to be prescribed now in the state. Amphetamines for quite some time, but marijuana more recently. Is that going to be an acceptable practice in your facility? And that may be something that you have more oversight on. So an individual that's taking Adderall for ADHD may need more frequent visits to ensure that they're taking their medications as prescribed, and using the prescription monitoring database to ensure that they're filling the prescriptions at the same level. And it may be that you've got to communicate with the other doctor that's prescribing those medications and getting releases signed. Now, methamphetamines, bath salts, and spice, or other medications. These medications impact the primary goals. So again, the primary goal for treatment is to reduce deaths, reduce hospitalizations, and reduce incarceration. If an individual is using illicit substances, they are at higher risk of death, hospitalization, and incarceration. There's not a linked exacerbation between those substances, but the primary goal is at higher risk due to injection, illegal activities, and few people can use these substances and succeed in the secondary goals. So attempts to engage the client in activities to reduce the use of these substances are important. With our goal of reducing deaths, incarceration, and hospitalization, how do we treat these substances? You link them with more intensive treatments. Outpatient is typically the go-to with medication-assisted treatment, so maybe the individual needs intensive outpatient. Maybe they need more frequent individual or group sessions, maybe more frequent physician services to promote the use of only the medications prescribed. Now, if we taper these clients or discharge them from services, they will be at more risk to go out and use opioids, which is the highest risk at this point, given the nature of the opioid epidemic. Now, Mark, I believe we were going to take a break here. Is that correct?
Yes, if you feel comfortable, we can go ahead and do the break right now.
Yeah, we can do the break, or I can keep powering on. It's up to you.
Yeah, let's go ahead and hit the break. We're going to take a 5-minute intermission, stand up, stretch out. We'll meet back here sharply at 11:03 a.m. Thank you, guys. Hello, Mr. Perry.
Yes, sir.
All right. If you're ready to go, I'll pass control back over to you and keep powering through. You're doing a great job, by the way.
Yeah, I appreciate that. I'm excited that this many people want to listen to me talk this long. All right. So at this point, let's see where we're at with the slides. Here we go. How do we get back to the slides?
Give me just a moment.
All right. Thank you. All right, great. All right, so up to this point, we've addressed how to engage individuals prior to and during treatment. There are going to be individuals that remain in treatment for the remainder of their life, and their retention will be based on ongoing engagement. Now, for the rest of the individual, services eventually come to an end. The most common way to end services is the successful completion, the inability to pay, or maybe the individual leaves abruptly or against staff advice. And then finally, the one that we have the most control over, the administrative discharge. All right, so an individual successfully completes. How do we make the client feel valued and welcome to return? It's that customer service. We want to say, we're so happy that you're completing services, and then we want to send a message to the client. The message is that the door's open again. We want you to return, and we want to not insinuate that the risk of relapse is higher than the risk of continued abstinence. So we want to encourage them to return if they need to. We also want to encourage referrals. Send your friends, send your family, your coworkers. Alumni groups are often a very large referral source, and it sends the message that we would also readmit the individual if they needed. Now, the inability to pay. So a client loses their insurance, employment, or family members discontinue funding their treatment. So how do you retain that individual if they're unable to pay for daily dose? For-profit or not-for-profit, there's a cost of doing business. What alternatives can be reached to assist a client in maintaining treatment services? Payment plans that can be used. Is there a work program that could be implemented to offset the cost? If payment plans and work programs aren't available, how do you manage the taper for medications without putting the client at a higher risk of relapse due to withdrawal craving symptoms that may return? Now, one study argues that a sudden discharge from treatment for inability to pay should never occur. We want the client to be able to return to services when their financial situation improves. And then, of course, we have the alternative funding sources. We've got the STR, the SOR, DCF, or OSCA funding. What if an individual stops treatment suddenly? What if they leave, maybe they've got a family emergency, or maybe they just decide that they've got conflict? So what efforts are we making to re-engage the client? Some staff members should make efforts to engage the client and determine the reason. Did the individual get arrested? Did they end up in a hospital for a medical emergency? Maybe they had an altercation with the staff or another client that could be resolved. Even if it can't be resolved, making efforts to re-engage that individual leaves the door open for future engagement. It shows that we care about the individual and their recovery goals. Now, administratively discharged. The rates for administrative discharge vary by the level of care. As you can see, the short-term programs tend to have the lowest levels of administrative discharge, whereas the long-term programs tend to have the highest. So it's easy for an individual that stays on a methadone clinic for 3 years or 5 years. It's on the greater timeline, it's easier for an individual to be administratively discharged compared to a client that's in a hospital bed for 3 to 5 to 7 days. So one study found that there were 5 consistent reasons for administrative discharge. To preserve the integrity of the treatment milieu. If we discharge disruptions and negative behaviors, it sends the message that one person won't impact the treatment of others. To use the limited services to the best of our abilities. There is a much larger need than available services. If we discharge those not responding, we open up access to those who really want it. To protect the reputation of the treatment program, if we allow this client to remain in treatment, it makes our program look bad, and it sends the message that we promote this type of behavior. If someone tests positive in treatment and is retained, what message is sent to the community? To prevent enabling from the treatment provider, if we don't stop the relationship with the client, we are enabling the individual to continue the behaviors. We provide the client with a wake-up call. The idea is perpetuated when the clients return to treatment claiming they weren't ready for treatment and needed to experience it firsthand. To fulfill the ethical obligation of terminating and referring those who fail to respond. The assumption is that we need to protect clients from continuing exposure to treatments that are ineffective or potentially harmful. So we know why we, the provider, discharge clients. These 5 reasons all make sense from the treatment side, the business side, and the non-disruptive client side. If we are treating clients that aren't motivated, impacting other clients, or aren't the best use of resources, or doing the best job we can to impact the community, not only the substance using community, but the community as a whole. We aren't in the business of treatment for one individual. We're in the business of treating hundreds, if not thousands, of individuals. So the thinking is easy to get behind, but it's also that thinking of business as usual. So the arguments against administrative discharge. It doesn't make sense to discharge clients for the symptoms of their disease. If someone is using drugs or alcohol, it reinforces their need for treatment. We tell the greater community that we provide a service to help people that can't quit drugs or alcohol, and then we turn around and tell the individual that they can't participate in our treatment because they use drugs and alcohol. If the client had the ability to control their drug or alcohol use, they would not need treatment. So providing the client with more resources and patience is more likely to result in their individual success. Expelling them from treatment services sends them back into the drug-infested lifestyle that they are hoping to eliminate from their lives. Now, when a client is discharged, the loss of treatment is rarely the concern. The concern becomes loss of a job, probation issues, or child welfare complications. It could be family concerns. The treatment providers become part of their problem instead of a source of help. This often leads to a return to alcohol or drug use. If I can't even get help from a drug treatment center, why bother? So when someone's admin discharged from treatment, what terminology is used? Throwing or kicking someone out of treatment. What message does this send to the client? They were violently removed from services, and their ability to trust a professional diminishes. It also sends the message that the client must fall in line with treatment recommendations, or there's no chance of success. This goes back to the staff really understanding addiction, particularly those with a history of addiction themselves. If they went to treatment and got clean the abstinent way, they may be surrounded by the 12-step community that reinforces that people only get clean that way. It's a very black-white style of looking at addiction. So even if they accept that MAT is an evidence-based practice that supports recovery, they may not recognize the frequent relapsing or difficulty leaving negative support systems that promote negative behaviors. What about things like sexual activity between clients? Clearly, we can't allow harassment or assaults, but if 2 consenting adults engage in sexual activity in a treatment center, how does that impact their ability to continue treatment? We've removed drugs and alcohol from their life, and they seek excitement and pleasure in a time where it's often completely absent from their life. Gambling, risk-taking behaviors, and other sexual activity should be expected in early recovery, and we should be prepared to address these concerns and promote alternatives. Now, considering the first case study, our opiate-using client presents to detox in residential services. He's struggling with cravings and withdrawal despite detox. The client disengaged from residential services to go use and ends up sleeping in his car. It's the client's fault for using and not sticking it out in the bed that he had available. The treatment provider fills the bed with the next client, but doesn't consider what it could have done differently. It's the client's fault for relapsing. It's the client's fault for choosing the wrong level of care. Alternatively, a client continues to use the same service, successfully completes or is admin discharged, then relapses. The client is brought in time and time again, but no one considers that the level of care is not appropriate setting. It's the client's responsibility to follow program rules or to implement the skills acquired in the level of care. So we are casting blame on the client and not evaluating how we continue to do things. We fall into the business as usual mindset that may be laughed at in the 10 to 20 years. So we have to discontinue blaming the client and evaluate how we do things. So how do we improve? We've discussed getting clients in. We've discussed how to engage them when they're in, and then we've discussed how to transition them out and reasons for administrative discharge. So how do we improve? How do we go? Where do we go from here? Starts with the first contact. So improve the pre-treatment engagement and orientation process. Are you treating the client as an individual with the expectation that he or she meet our primary goals through this intervention? Is the process client-centered? Is it culturally sensitive? Are you engaging a client in an intervention that is impossible to meet? Are you evaluating your process for administratively discharging clients? What led to the admin discharge? What changes are you implementing so that it doesn't repeat again? Was the client given proper orientation? Do they have access to their preferences for treatment? Did your staff return phone calls in a timely manner? Was there an aversion to the medication? Are your dosing hours effective? Is your program discharging clients too quickly for low-risk behaviors? Are drug screens being used for diversion or punishment? And is your staff really knowledgeable about addiction? Are you considered transferring between levels of care when the service setting is not meeting the client's need? When transferring the client, are you doing a jump job on the other provider, or are you seeing the client through? If the individual is not doing well in the outpatient setting through medication-assisted treatment, and you link them with the residential care, are you following the client for that duration, or are you leaving them for the 30 or 60 or 90 days when the residential and let them come back? So for our methadone program, we changed the procedure for new intakes. We were losing clients on the front end. At one point, there was a large window of time between contacting the clinic, coming in for an orientation, scheduling an appointment with a counselor for psychosocial assessment and treatment planning, another appointment for nursing, and finally a doctor appointment. Now, the process could take up to 2 weeks at a time. I felt like we were losing clients to rules that they may have heard while under the influence or withdrawal, or possibly a combination, depending on the length of time they were with us. How can you possibly remember lockbox rules when you were focused on getting your next fix because the counselor told you you'd see the doctor in 3 days for methadone? So this process changed to allow admission in less than a week, but it still occurs over multiple days. So we're changing the procedure to get the package to the client at first contact, whether they're coming in the front door, getting an email, or going to the website. The client will then return to the packet and be scheduled in 1 day to see the admin, staff, counselor, nurse, and doctor. While it's a long day, it's generally easier to take off 1 full day of work than it is 2 to 3 separate days in a week for 2 to 3 hours each time. In a few months, we'll review this process to see if it has helped us regain our engaged clients. Other ways that we can improve is to take advantage of partnerships with managed care programs and managing entities. We can engage the peer community. Peer integration is critical. And we can improve relationships with emergency departments in the justice system for easier access to a population that is often missed. Other ways, we can evaluate the staff and rules. Are your rules helpful to the retention of clients? Are they there to serve as a reminder of the previous program director? Saying things like, "It has been our experience," may prove to be more valuable than "thou shalt not." My experience has been that our clients don't do well with authority, and they push against it to meet their needs. Is your staff educated and aware of their role in the addiction process? Are they receiving adequate supervision and education to keep up with the changing guidelines in the practice of addiction treatment? Consider having one contact early in recovery, someone that can provide motivation and understands the struggle of early admission into treatment, and particularly medication-assisted treatments. It could be someone that's in the lobby for a few days a week and shows excitement that the person made it that day, or is available to discuss any concerns that presented outside of clinic hours. It could be an individual that sends a text message of encouragement to the newly inducted buprenorphine or injectable naltrexone client. And this reaffirms the message of community that the individual is not on his or her own. Is the person relapsing or acting out because the doses are left to a minimal dose due to provider preferences? Finding the right dose for the person should be based on client symptoms and not specific preferences of the provider. One study found that adequate dosing is the single most important contributor to methadone maintenance treatment retention. Although adequate dosing alone is not sufficient to stop alcohol or drug use among clients deeply enmeshed in drug-using subcultures. If the client is experiencing withdrawal symptoms, their behavior would be in response to the negative stimuli, and that could lead to administrative discharge. If an individual comes in and they're grumpy and angry and they're snapping at people, it may be a result of withdrawal or not being on the right dose. So dose should be given at the right level, and there shouldn't be a minimum or a set goal. And leave the door open. When a client leaves services, regardless of the method, leave the door open for readmission or referrals from your agency. The client may not be appropriate in your setting, but we should ensure that they have access to services that would meet their needs. All right, here's the references. Are there any questions? Anything that maybe I can explain or help with?
Just a note, remember attendees, you can ask questions in the QA panel.
All right. Additionally, I've left my email address in the front slides. If you have any questions, feel free to email me or give me a call. I'd be happy to answer any questions.
We'll let 30 more seconds go by for any questions to come in,
Sure.
and then we'll call it a wrap.
Sure. So the first question is, Matt, more of a business success model? You use retention, business as usual, sale. My experience is that it is a business. You want to retain people, and it's more valuable to retain people than to necessarily follow the rules that we've set in place. Now, we're in a place where people are dying. People are sick, they're not able to function, so we want to keep them in treatment to avoid those risks. So I do treat it as a business, but also with the clinical knowledge. It's a different type of business, but we are selling hope and recovery. All right, so the next question is there a good way to address the not really in recovery clients on medications? That's a tough group. The group that is not really in recovery, if they're coming in, what is their recovery? There's Dustin with Rebel Recovery, he's a peer specialist down in South Florida. He's taught me a lot. He says that an individual that uses IV drug use every day, he uses a needle, and he stops using the needle for a couple of days. He's successful in some level, right? So we have to build on that success. We have to build on they're taking their medications. They're making some effort. Is it the effort that we want? Of course not. We want them to work full time and pay taxes and show up to their appointments on time. But the reality is they show up to appointments 45 minutes late, if at all the right day. So the person that's not really in recovery, what are the strengths that we can look at to encourage them? What have they done well up to this point? What have they stopped? What have they reduced? Or what have they maintained? An individual that takes methadone every day and stays at the same dose but doesn't go to counseling or is still hanging out with the wrong people, they're not using opiates, so that they are in recovery to some level. It's not the 12-step recovery. It's not the 10-year-old recovery, but it's some level of recovery. Let's see. we'll do the next one. Not a question, but a comment. Thank you for a reminder about kicking out of that client who may not be fully engaged. So you're welcome. That kicking out, that throwing out is such powerful language. So we want to retain as many people, and we don't want to kick anybody out. We want to push them towards the next direction. So if our program's not the correct one, we want to push them to the next direction. We don't want to kick them out. We want to encourage them to continue to be involved in the community. Active strategies to keep staff positive, not overwhelmed given the stakes. Oh my goodness, that is a tough one. This is one of those things that our clients die. We sit in on debriefings more than I would like, a couple of times a year, unfortunately. Encouraging self-care. Pensacola's got one of the nicest beaches in the state. Sorry, the rest of the state, but so encouraging our clients to go out, our staff to go out and take advantage of the beach, taking some time off here and there, taking half days, bringing staff lunches, anything we can to promote just the personal well-being. It's easy to get burned out, and we're, especially with the state funding population, we're all tasked with carrying bigger caseloads than are realistically managed. So give them any opportunity they can to take a break. Let's see. Active strategies to keep staff positive and not overwhelmed. Clarifying, when MAT patients go to superior meetings, they often get the attitude that they are not really in recovery. Okay. Peer support meetings are very tough. We have actually not encouraged our clients to get involved with the NA meetings because they're not really welcome. There's a handful of people in the 12-step community that does support medication-assisted treatment, but it's such a small group that we really encourage them to build a community from the groups that they attend here. One of our SDR transitions is that we're going to have a dedicated space on our campus where they can meet once a week as ongoing continuing care, client-led, and hopefully that will build into a more anonymous type group. Let's see, long-term success, 1 year, 5-year mark. I will see if I can find some resources for you, Marilyn, and send those out to you if you want to send me an email. Any tips on patient retention, engagement, and outpatient therapy? Is there a time frame that you keep a patient in the program if they're unwilling to receive OP therapy? There is a time frame, and this is the difficult piece for counselors is I've got clients that haven't been to group in 2 or 3 months. When they come and see the doctor, I try to meet with them. I try to say, hey, what's going on? What can we do to get you engaged? It's very difficult for me. I come from the abstinence background. I came from the drug court system into residential, and I've transitioned into the medication-assisted treatment population. So going from the counseling priority to medication priority and trying to find the balance is very difficult. But the research is showing that those that engage in medication alone, they retain in treatment. So our goal is to keep them on that medication and not discharge them for not going to group. Now, there's a certain point where, if they've been 2 months without going to a group or an individual, I'll have them see the doctor more frequently. So instead of seeing the doctor once a month for Suboxone, they'll see the doctor 2 or 3 times a month. And that promotes that kind of the reduction in the takeouts, if you will, on the kind of the methadone model. With methadone, we won't do phase advancements if somebody's not attending counseling. So there's rewards for attending, and you just don't get those rewards if you don't attend. So it's a very difficult balance between those that aren't going to outpatient therapy.
Thank you, Dustin, for a wonderful presentation. I do have to end Q&A at this point, and we're going to wrap up with a conclusion. It's very well done presentation, and we thank you.
I appreciate it. Thank you, everybody, for joining.
Thank you, attendees, for participating in today's webinar. When I conclude today's webinar, your browser will take you to an evaluation on FATA's new website. If you want to receive CE credits or a statement of credit for this event, please complete the evaluation. You will be prompted to register or sign in to complete the evaluation. You can register as a visitor at no cost for CEs to be reported to CE Broker for FLA licensed healthcare practitioners. You must provide an accurate Florida Department of Health license prefix and number the first time you register. After you register or sign in, you will be directed onward to the evaluation. You must consider using the same email when you register for webinars through our WebEx link and when you set up your profile in the FATA system. This helps connect your attendance and your profile. You will get a second opportunity to complete the evaluation through a follow-up email later today in about 30 minutes. The sender will be Messenger at WebEx. Evaluations will close at midnight on Wednesday, February 5th. We do not email statements of credit. Instead, after we verify attendance and completion of the evaluation, a statement of credit will be generated as a journal entry within your profile. Thank you for participating in today's webinar. We'd also like to recognize and thank especially the Florida Department of Children and Families Offices of Substance Abuse and Mental Health for funding today's education. Have a great rest of your day, and please hold on for the evaluation.